Yes, sir.
Okay. Okay. So the basic uh, resource I had taken for this topic is from the ISCCM guidelines. So coming to the introduction, quality indicator is a measure of structure, process, or outcome that could be used by local teams to improve care. So it helps to understand a system, compare it, and improve it. So that is the main reason why quality indicators are used. So the main objective is to select very common parameters, mainly focusing on outcomes like morbidity and mortality, use of process measures, assess for infections, human resources, and safety. So the parameters that are routinely used in ICU practice are in relation to mortality is the SMR. There is a standardized mortality rate. With regard to morbidity, iatrogenic pneumothorax rate and decubitus ulcer rates, operational or process are length of stay and ICU readmission rates, error in patient safety, patient fall rate, medication error, needle stick injury rate, reintubation rates. With regard to infection control, you have VAP, CRBC, COTI rates, and resistance rates. And human resources, you have overall employee satisfaction rates. So these are the important ones that you need to definitely know about. So first coming to SMR or risk adjusted mortality rate. So the main rationale is raw mortality is not a good indicator of quality as it does not consider the difference in cases or the severity of illness. That is an important point that needs to be kept in mind. So use of SMR calculated from approximately calibrated severity of illness scores enable comparative auditing controlling for the severity of illness by predictive models. All right. So the population that is taken into account is are all patients admitted to the ICU. So the formula is the observed rate, that is the actual death rate in the ICU divided by the risk adjusted expected rate into 100. So how do you interpret this formula is, so you have an ICU of 10 beds and in a month you have had an admission of about 100 patients and in about those 100 patients, 10 patients have died. So that would be the observed rate of actual deaths. So the risk adjusted expected rate, that is if you are using an Apache 2 score, for all the patients who are admitted in the ICU, you calculate the Apache 2 score and then you take an average of that. So that would give you your denominator. So then you will have to, based on the Apache 2 score that you get, that would give you the predicted mortality. All right. So the numerator will have your ICU death rate and the denominator will have the Apache rate based mortality percentage. So that needs to be calculated and multiplied by 100. So the interpretation, if it is equal to 100, then the ICU mortality rate is equal to the expected rate. If it is more than that, then ICU mortality rate is more than the expected rate. And if it is less than 100, then the ICU mortality rate is less than the expected rate. Then coming to iatrogenic pneumothorax. So procedure-related pneumothorax is associated with increased morbidity and mortality, prolonged ICU stay, and increased costs. So population, it includes all patients admitted to the ICU, and the formula is number of cases of iatrogenic pneumothorax divided by number of ICU cases in a month by 1000. So the benchmark is 0.83 per 1000 cases. So from an exam perspective, till your practical exam gets over, please remember these benchmarks. Either write it in a piece of paper and look through it every day, or have any other sources through which you can regularly revise it. Then coming to decubitus pressure ulcers. So decubitus ulcers and pressure sores are synonymous. So prolonged uninterrupted pressure over bony prominences cause necrosis and ulceration. Hip and buttocks contribute to 67% of the pressure source. So it is associated with increased cause and infection risks. So again, the population here include all patients admitted to the ICU, and the formula goes by the number of cases with pressure ulcers de novo, which has occurred newly, by the number of ICU cases in a month divided by 1000. So here the benchmark goes as 22.7 per 1000 cases. For iatrogenic pneumothorax, it was 0.83. Here it is 22.7, or 3 to 11% of ICU cases. So length of ICU stay. So the main rationale for doing this testing is ICU beds are limited in any hospital. That is one thing all of you would know. So thus rational is used for needing patient is necessary. So the length of stay is used to assess the quality of care and resource utilization. So the total hours and days patients managed in the ICU with midnight bed occupancy is taken as the variable under consideration, which is the most accurate. So I'll again discuss about this in the formula. So the population is all the patients who are admitted to the intensive care unit. So the formula goes by the total occupied bed days, that is the inpatient days, divided by the total number of ICU discharges or deaths in a given time frame, usually a month or a year. All right. So the total occupied bed days, how do you take it into consideration? So if your ICU consists of 10 beds, all right, it's not very common that all beds are going to be filled most of the time. Most of the time it would have six beds when may be filled, or sometimes there may be eight beds which may be filled, or there may be few times when all the beds are filled. So usually if you ask your senior staff nurse who's in charge, they would have a midnight census. So based on that midnight census, you can calculate the number of patients who are there at that point of time. So that every day, that midnight census needs to be calculated for that whole month and then averaged. So that would give you the numerator, total occupied bed days. The denominator is pretty straightforward. The total number of ICU discharges or deaths in a given time frame. So usually we take it as a monthly basis. Usually the clinical audits or this meets usually happen on a monthly basis. So at that time, you can take it for a month's basis and then use it as the denominator. So since the data distribution for occupied bed days is likely to be skewed, you need to go with the median value because it provides the best accuracy. All right. So the benchmark here is for a general ICU, it is about 4.36 days, and for a vascular ICU, it is 2.36 days. So ICU readmission rate, that is within 48 hours of ICU discharge. So the main rationale here is early high readmission rate, that is within 48 hours, suggests poor ICU discharge decision making. So this can be due to three reasons. One, discharges occurring before the patient is ready for ward-based care, incorrect use of ward care, or deficient handing over to staff taking over care and responsibilities of the patient. So these are the three circumstances where readmissions can occur. So the population here are all patients admitted to the ICU, and the formula is pretty straightforward. The number of readmitted patients by the total number of patients managed in the ICU into 100. So the benchmark is 5 to 6%. Then comes patient fall rate. So the main rationale for this is an untoward event which results in patient coming to rest unintentionally on the floor or another lower surface. It can be anticipated or unanticipated accidental event which is associated with increased morbidity, prolonged stay, and customer dissatisfaction. So here again the population includes all patients in the ICU, and the formula goes by the number of falls by the number of bed days. So the number of bed days is the one which he had mentioned previously. So you take the midnight census, you calculate the number of beds that have been occupied, then take it for the full month and average it. So that would give you the denominator. So the interpretation would be without injury, it is about 2 to 2.6 per 1,000 patient days, and with injury, it is 0.22 to 0.7 per 1,000 patient days. Then coming to medication error. So the rationale for this is medication error can be due to wrong prescription, wrong dose, or a communication gap. Many a times, verbal orders, when it is being given, it can lead to a very, very high chance of medication error. So usually in most scenarios and now in most of the NABH hospitals, it is now mainly a standard norm that you need to give your orders in writing. So it can occur at a mean rate of 19% of hospitalized patients, and in about 2% of them, this can cause significant patient harm. So it includes all patients admitted to the ICU, and the formula goes by the number of errors by the number of bed days divided by 1,000. So the interpretation is a median of 105.9 per 1000 patient days. So needle stick injury, the main rationale for it is needle stick injury is a penetrating stab wound from needle or other sharp objects that may or may not be associated with exposure to blood or other body fluids associated with transmission of bloodborne pathogens. So it is a preventable injury, hence adequate training to a healthcare provider is a must. So it includes all healthcare workers. So among all the previous scores that, so previous formulas that we had, population that we had seen, this one includes healthcare workers. So the formula is number of needle stick injuries reported in a month divided by the total of number of staffs in the ICU per 10,000 venipunctures. So the interpretation is the benchmark should be less than 0.94 per 10,000 venipunctures. So reintubation rates. So the rationale is reintubation within 48 hours of extubation. So that is the reintubation rate. So why this is concerning is accidental extubation and subsequent reintubation can lead to prolonged stay, prolonged ventilation, and higher nosocomial pneumonia rates. So here it includes all patients admitted to the ICU, and the formula is straightforward. Number of patients reintubated by the number of patients extubated into 100. So the benchmark is 12%. So next is the infection control related parameters. So first one is the VAP rates. So VAP increases morbidity and mortality plus associated with increased ICU length of stay and increased cost. So it includes all the patients admitted to the ICU, and the formula goes by the number of patients with VAP divided by the number of ventilator days. So the number of ventilator days is the number of days the patient is on is mechanically ventilated with either a endotracheal tube or a tracheostomy tube. Now, how do you go about ventilator days? It is almost similar to the number of bed days or occupied bed days. It's almost similar to that. So you have a 10-bedded ICU and you have about 6 patients. So in that, 3 patients are on mechanical ventilation through an endotracheal tube. All right. So those 3 patients at the midnight census are taken as a number of 3. So for the whole month, the number of patients who are there on mechanical ventilation are taken into consideration as a part of the midnight census. And at the end of the month, these numbers are then added up and averaged. So that would give you a denominator as the number of ventilator days. So the interpretation, the usual benchmark is for trauma ICU, it is 9.3 per 1000 ventilator days. Medical ICU, it's 2.5. Neuro ICU, it is 7.1. And neurosurgical ICU, it is 6.5. Bloodstream infections due to central line rates. So the use of CVCs is indispensable in the treatment of critically ill patients. So infections is one of the most common complications of intravascular catheters. And this is also associated with increased morbidity and increased ICU length of stay, and they say by about 5 to 8 days. So the main population are all patients admitted to the ICU, and the formula goes by number of patients diagnosed with the central line associated bloodstream infection by the number of central line days in a month. So this formula is also similar to that of your number of ventilator days and number of bed days. So in patients who are admitted in your ICU, you have a 10-bedded ICU, and in that 10 beds, your ICU census is about 6, and the number of patients with the central line is about 2, as per the midnight census. The next day it is 4, the next day it is about 2, because some patients may be shifted to ward with the central line. So then they may not be included in their numbers. So that number of patients who are there with the central line and during your midnight census are taken into account. And at the end of the month, all these numbers are averaged, and that would give you your denominator. So for benchmarking, usually in medical ICUs, 2 to 4 per 1000 central line days is usually taken as the benchmark. For trauma ICU, it is 4. Neuro ICU, it is 1.2, and coronary ICU, it is 2.1. So 2.4, 4, 1.2, and 2.1. So for CAR-T rates, so for all infection related, you can mention it is associated with increased morbidity, increased length of stay, and increased cost. So invariably, these are the things that occur. So it includes all patients admitted to the ICU. So the formula is number of patients diagnosed with CAR-T divided by the number of catheter days. It is similar explanation like I told for ventilator days and uh, catheter days, central line catheter days. So here the benchmark is for medical ICU it is 4.1, burns ICU is 7.7, neurosurgical ICU it is 6.8, and surgical ICU it is 4.1. So for medical and surgical ICU, CAR-T rates are almost similar. Whereas for burns it is higher and neurosurgical ICU it is lesser compared to the burns ICU. Then comes the resistance index. So the main rationale is to assess the epidemiological trends of organisms in ICU. So the antimicrobial resistance is usually associated with increased mortality, morbidity, financial burden, and length of stay. So it includes all patients admitted to the ICU. So the formula goes by the number of resistant isolates by the number of isolates tested into 100. The important thing to note here is at least 30 isolates are needed to get a good accuracy and precision. So it varies from institution to institution. And the important thing is it provides the foundation for selection of antibiotics for a specific set of infections. All right. In many of our hospital acquired infections, when we write the answers, we always say based on local antibiogram, local epidemiological data, all that is based on these formulas and derivations. Then comes the human resource related parameters, overall employee satisfaction. So the main rationale is satisfaction level of staffs working in ICU is assessed. So satisfied workforce gives better output and the retention rate is very high. So many a times in many ICUs, if the pay is not good or the workload is very hectic, then many people would have double minds. And if they are not, there is another center where they're ready to provide better opportunities and with a more flexible timing and work, then they would have a tendency to go there. So all those things also need to be looked into. So the population is it includes all staffs working in the ICU, and the formula is usually a questionnaire based format from 1 to 5, where 1 is the lowest satisfaction and 5 is the highest satisfaction. The ideal benchmark needs to be 4. Then customer satisfaction rate. So the main rationale is patient satisfaction is perceived parameter by the patient. It reflects performance of the hospital as reflected by the patients. So it includes all the patients admitted to the ICU capable of giving feedbacks. So it's a questionnaire based assessment with a point of 1 to 10, where 10 indicates the best possible service. So the benchmark is satisfaction to physician communication should be at least 80%, nurse communication 74%, cleanliness 70%, noise 50%, pain management 68%, and recommends hospital orders is 68%. So you can remember it as 80, 75, 70, 50, 68, and 68. All right. So thank you. So why I was emphasizing on quality indicators is from theory, usually every alternate year, almost they have asked questions related to quality indicators. That is one thing. Second thing, in your practicals during the afternoon session, one section is specifically dedicated to quality indicators. Because many people don't concentrate on this, the marks they obtain in this area is relatively less. But there is only a certain set of questions that they can ask related to quality indicators. And if you are able to answer them, you would be able to score at least 90% of the marks related to that. So I would highly recommend everyone to give a lot of importance to the quality indicators. Thank you.